I'd just like to introduce our next speaker, Rob Chand, who's consultant at Shrewsbury and Telford, who's talking about his project on QI increasing transplantation rates. Thank you, Rob.
Thanks, Rosie. Thank you very much. Let's get this going. Okay, so I'm Rob Chand. I'm at Shrewsbury and Telford NHS Trust. We're quite a small referring centre. We have about a 500,000 catchment area. So where were we? Well, with GIRFT, we were shown to be one of the probably the worst in the UK as regards listing patients for transplantation in a timely manner once they've hit dialysis. Our prevalent and incident rates were one of the lowest in the country, and I joined the trust at the end of 2016. So this was a great project to be involved with, mainly because we could only improve. So I always had that on my side in some ways. So what did we do? Well, we basically looked at the communication between the teams. There was a significant delay of referrals being left on people's desks, things not being completed, no chats amongst the teams. And that's echoed with some of our other talks, is that communication within the team, which was key. We also needed to change the culture within the department. We were very much, we had an excellent home peritoneal dialysis and home therapies service, but we never had a transplant first focus. And with Kerry's leadership in between 2015 and 18 with transplant first, that's certainly something that we changed within our meetings. We also had a set up quarterly QAs amongst patients with named consultants responsible for their care and transplant workup, along with our transplant nursing team. We tried to ensure that everyone had a decision about whether they're suitable or unsuitable and where they were in the pathway by the time their EGFR was 15. And we kept our teams updated every couple of years. We used clinical vision to show where patients were within the transplant pathway. And that certainly helped when we were trying to figure out, what's the holdup. So where we were with our adult living preemptive transplant rates, when GIRFT arrived, we were about 18%, and you could see by the following year we had already started some of our work to improve our preemptive rates up to 39%. Certainly the idea of having that speciality person that you could talk to quickly when you're working somebody out, or whether it's a donor or a recipient, was key. We actually had 2 named cardiologists on each of our sites of our hospital, where rather than waiting 6 to 9 months to get a cardiology outpatient opinion, we could actually do this via a quick email exchange. Where it was safe to do so. And certainly in the blue, our time to discuss to actually referring the patient to our tertiary centre, transplanting centre, certainly went down from about 6.5 months. We've got back at the end of 2021, we were down to just under 4 months. Our transplanting centres also significantly reduced their time waited upon receiving the referral and actually listing the patient as well. And what we found on the right side of the graph is that the earlier we started, in general, those patients remained at referral if we started earlier. So where were we at the end of our 2021? Well, all of our patients are now listed by 2 years as that metric, if they presented in a timely manner. We have our incident transplant population, the red star on the bottom left, coming back to the national average, and we're getting there with our incident transplant rate population. We do have a large legacy of patients not being transplanted, so we're getting there with our prevalent transplant populations, getting towards the median. So what next? After Transplant First, we changed our focus to a transplant improvement group. It's pretty similar. We just wanted to carry on the great work that had already been done, and Kerry was key in implementing this as in the West Midlands region. So what we did, we had a bit of networking in the British Transplant Society with Lisa Burnap in 2019, just over a chat. She kindly visited our centre and helped us with a workforce model, because at that point in time we had two consultants, myself and Dr. Ramados, who were just almost doing this on the side without a job, a PA in our job plan to focus solely on transplantation, and one band 6 nurse at that time who were just created to band 7. We managed to get administrative support, and we managed to increase our team to 2 extra band 6s, Hannah in October 2021 and Katie in May 2022. And with the Midlands Kidney Network, extra funding was achieved for a band 6 nurse, Leanna, in January 2023. This has helped us focus a lot more on transplantation. We don't separate the teams out in terms of deceased donor or living kidney transplantation. This also allowed us to continue our pre-transplant education clinic, which our nursing staff are excellent at doing, just to set realistic targets about what's going to happen in their journey during and after transplantation. As you can see, our number of referrals and therefore workload demand on Poor Sue as our band 7 dramatically changed after COVID, and I think that as a result, we're hopefully going to get more transplants, going up to 50 referrals a year now. With the K-Quip, we designed a driver diagram to try and get, we noticed a lot of our living donors, although we were doing 4 to 8 per year, most of them were post dialysis, unfortunately. And a lot of that's because people have come forward for living donation once they realised how their loved one is actually, how their health is on dialysis. Most of our focus is trying to get that preemptive listing done and early identification of donors. On the right-hand side in green are the things that we've done this year, namely, not relying on just medical staff to be able to request lung function tests and 24-hour blood pressure monitoring for donors, changing that, not waiting for glucose tolerance tests anymore, relying more on HbA1cs, having 3 monthly MDT meetings, but including our living donor coordinators at referring centres to join us at that meeting. We did, in blue, we did start emailing some potential donors prior to their outpatients with us to see if that would help reduce DNA rates, but actually it didn't make a difference, so we've scrapped that as we've gone on. And the only thing we haven't really done is a desired 18-week target. With the identification early, we essentially, it's a bit like a Tango equation. We've got a list of people between 15 and 30 EGFR and aged under 75 and each named consultant, and you can have a quick look at the decline in their EGFR on a graph with an idea of what the latest ACR is. And that's helped us on an MDT with our transplant nurses and our advanced kidney care clinic team to say, look, who's actually declining? Do we need to really have a pre chat about living donation as a gentle introduction so we can identify them in a timely manner? It's also helped us focus on, we've got a very good bariatric service here, and if we can identify potential recipients and donors a couple of years before they're needed, we can actually get them focused on their weight reduction, and that's helped. Well, hopefully in the next couple of years, help reduce delay. So as my last slide, where are we with a rolling 12-month preemptive transplant listing on our Transplant First data tool? We're getting there. We're getting towards the 60% now in the last couple of quarters. And our prevalent transplant rates, transplant recipients, has increased from about just under 140 to just shy of 200 now over the last 6 years. Thank you.
Thanks, Rob. A real story of persistence there and using QI methodology to just keep on going and seeing incremental gains. So thanks so much.